Critical Thinking and Coding Tips for Chapter 23. Now, our first critical thinking question: what is the difference between an open and closed fracture? Does an open and closed reduction indicate the type of fracture that it is being reduced? And our answer: a closed fracture is a broken bone, but the skin around the bone remains intact. When the bone exits and is visible at the fracture site through the skin, it's considered an open fracture. It can be confusing when there is a superficial injury but the fracture is not exposed. In this case, the fracture itself is closed and not open. If the documentation does not support open or closed, then assume it is closed. As in all injury coding, always sequence the most severe injury and/or fracture first. A diagnosis of open or closed fracture has no bearing on the fracture treatment being open or closed. Do not assume that an open fracture will always be reduced with an open approach. Likewise, a closed fracture may require open reduction. It's important not to link the type of fracture with the reduction that is performed. Review the documentation to determine the following. 1. Is the fracture open or closed? And 2. Is the reduction open or closed? Each of these questions may render two different answers. Now, closed reduction is a procedure that involves a surgeon manipulating the fractured bone without making an incision to expose the fracture. Small incisions might be made to place a fixation device, but it's still considered a closed reduction. An open reduction involves making an incision at the fracture site in order to reduce the fracture. Review the written or dictated operative report when coding any fracture reductions and query when the documentation is unclear. And our next question: what bones are included in the base of the skull? And our answer: on a radiology report and in documentation, the physician will often mention the specific bone and/or site of the fracture of the base of the skull. It's important for coders to be familiar with the anatomy of the base of the skull so that the correct codes can be assigned. The code for fracture of the base of the skull classifies to 801.XX. The occipital, or the bone at the base of the skull that contains the opening that allows the spinal cord to join the brain. The orbital roof is the top part of the orbit, and the orbit also has a floor. The sphenoid bone is a large bone containing the sphenoid sinus, forming part of the orbit. The temporal bones, which are two, these bones join the parietal, sphenoid, and occipital bones. And the cranial fossa, which there are the anterior, posterior, and middle. These form the floor of the cranial cavity and provide support for the lobes of the brain. And our last question: what is the difference between a sprain and a strain? And our answer: clinically speaking, these are two different injuries. However, they are coded identically. A sprain is defined as an injury to the ligaments, which are tissues that bind the bones together at the joints. A strain is an injury to the muscles or tendons that bind the muscles together that do not occur at the joint. The manifestations associated with sprains and strains are similar. They include swelling, pain, and difficulty using the specified area that has been injured. Okay, now for our coding tips. Chapter 23 introduces you to the coding of injuries and E-codes, which will also be explained in chapters 24 and 25 of the text. Now, E-codes are assigned to external causes of injuries and not the nature of the injuries, so therefore are never assigned as a principal diagnosis. The index to external causes of injuries begins on page 709 of the ICD-9 codebook. I always suggest you take a couple of minutes, scan through it to see what kind of codes are available. The tabular list for E-codes begins on page 1137. of the ICD-9-CM Codebook, and the table of drugs and chemicals begins on page 587 of the ICD-9-CM Codebook. It's a good idea to mark each of these sections so that you can turn to them quickly. Now, E-codes capture first how the injury happened or the cause of the injury. Next, the intent, unintentional or accidental, or intentional, such as a suicide or assault, and the place where the injury occurred. Now, do not use E849.9 if the place of occurrence is not stated. See page 653 of the text. The activity the person was involved in. And again, do not assign E030 unspecified activity if the activity is not stated in the index. See page 655 of the text. And the external cause status. And again, do not assign E000.9 unspecified external cause status if the status is not stated. See again page 655 of the text. There are many examples of how these are used in the chapters. Now, sequencing of multiple injury codes. When multiple injuries exist, code the most severe injury as the principal diagnosis. Usually, the most severe injury will receive the primary focus of treatment. Now, flail chest. Flail chest is one of the most severe thoracic injuries. It's the result of at least 4 fractured ribs in 2 different locations and pulmonary contusion leading to hypoventilation. On inhalation, the chest contracts instead of expanding as it normally should, and on expiration, the chest expands instead of contracting as it normally should. This can lead to hypoxemia and hypovolemia or myocardial failure. Also, when coding rib fractures, keep in mind that some DRGs reimburse differently depending upon the number of ribs fractured. It's important to review the documentation and radiology reports to see whether they correlate with each other. Now, the use of V-code 71.4, which is observation following other accident. Code B71.4 should be used in a case in which a patient arrives at a hospital after an accident, such as fall, motor vehicle, etc., and has no visible injuries or pain or etc. The only reason the patient is seen is to rule out a potential injury, such as a closed head injury. Such an injury may not be felt by the patient or observed by the physician and might be found only on a CT scan. Now keep in mind, if the patient has severe injuries, such as pain, etc., that warrants the admission, use the specific injury or pain code as the principal. If the patient has minor injuries and is admitted for observation for a more serious injury, the V code is appropriate as principal. Now, the difficulty in coding complicated wounds. Now, sequencing of complicated traumatic wounds can be challenging. The principal diagnosis depends on the circumstance of the admission. If the primary focus of care was for complication, for instance, cellulitis, then the cellulitis code is sequenced with the first with the complicated wound code as an additional code. For example, if IV antibiotics were given and a minimal wound care provided, then the cellulitis would be sequenced first. On the other hand, if the wound was irrigated, debrided, and sutured, the complicated wound would be sequenced first. And finally, how E-codes might be used for data collection and who might collect this data. An example would be that the Department of Motor Vehicles may want to see how many people are injured due to collision versus non-collision motor vehicle accidents. E-codes are a method to capture this data. Review the E-code section in the tabular section of the ICD-9-CM Codebook. Now, what other E-codes might be collected and for what purpose can you think of?